This is Michael Altos recording the Fundamentals of Clinical Pharmacology, Part 3. Now we're going to talk about biotransformation. The goal of biotransformation is really metabolism, which is to make this drug get chewed up and eliminated. And the way we do that usually is by making it hydrophilic. We want to make these drugs as water-soluble as possible so they can be excreted, usually through the urine, and this process mostly happens in the liver. There are two kinds of reactions that we commonly see when we talk about metabolism or biotransformation. Phase 1 reactions involve transforming the molecule using the cytochrome P450 enzyme family. These are different oxidation or reduction or hydrolysis reactions which perform a chemical reaction on the molecule in order to make it more water-soluble, more hydrophilic. There can be drug interactions that can alter the metabolism of our drugs. So for example, many of our drugs are metabolized by the cytochrome P450 3A4 or 3A5 subfamilies. Many opioids and benzodiazepines and local anesthetics. So you can imagine if you have a lot of drug all competing for this same family, metabolism might be slowed down. On the other hand, if you chronically use a drug and ramp up that enzyme, you teach the body that it needs to create more and more of that enzyme, then the drug might have a very short duration of action. We also have phase 2 type reactions. These are called conjugation reactions. Often a phase 1 metabolite goes on to phase 2. But conjugation means that you add some sort of a polar substance, again, for the goal of making it hydrophilic. So different substances like glucuronate or acetate or glutathione are added to the molecule to make it more water-soluble and easier to excrete. I should just point out that babies, neonates in particular, have very diminished phase 1 and phase 2 activity. Now we're going to spend some time talking about hepatic metabolism in detail. A few terms we want to define. First of all, we have the hepatic extraction ratio, which tells us what fraction of drug is removed as it courses through the blood into the liver and out the other side. And this is based on what's called intrinsic hepatic activity. We have a graph in our notes which calls it CLI for intrinsic clearance. Hepatic clearance, remember we said clearance was the idea that how much blood could I send to this organ and have it totally cleared out of drug per unit time? So the extraction ratio, which really is telling us how good is the liver at sucking drug out of this blood, and then of course blood flow, how much blood can I send to the liver? Those two variables are going to tell us how good the liver is at getting a certain drug out of the bloodstream. And so we have these complicated graphs which are in our notes, and we're going to discuss them in class. But for now, what I'd like to show is first the top graph. The top graph looks at hepatic clearance as a function of liver blood flow. So let's take a drug over here, this red line. As I send more blood flow to the liver, I get more hepatic clearance. You can see the liver is ready for whatever you can send it. Send as much blood flow as you want. The liver will do a great job of clearing drug out of it. And so you wouldn't be surprised that this has an intrinsic hepatic activity, that's the same as this over here, very high. On the other hand, we have a drug over here where at first, as I send more blood to the liver does more hepatic clearance, but quickly it levels out, and before long it doesn't matter how much blood flow I send to the liver, this is as much blood as the liver is able to clear per minute. And this is a patient who's got, this is a drug rather, who's got a rather low hepatic clearance of 0.5 instead of 25. So their intrinsic hepatic activity is much lower. And so different drugs fall at different places along here. Some drugs you can send as much blood flow to the liver as you want and the liver will metabolize them. Other drugs, the liver doesn't do a very good job of sucking them out of the bloodstream. And it doesn't matter how much blood flow you send, the liver gets maxed out. We can look at that in another way over here. Here we're looking at extraction ratio as a function of liver blood flow. So let's talk through this for a minute. Let's go back to our red drug. This drug, we say that at a perfect extraction ratio. The liver can take out every last drop of drug that comes to it. So as the liver blood flow increases, it's still doing a really good job of getting almost all of the drug out of the blood, no matter how fast you send it to the liver. But going back to this drug, so when the blood flow is very, very slow, the liver has lots of time to try and get drug out of the bloodstream and metabolize it. But as we send blood faster and faster through the liver becomes less and less able to extract 100% of drug out of the bloodstream before it passes through the liver. And this again is what we call a rather low intrinsic hepatic activity. We'll talk about this in class some more, but I'd like you to just be aware that different drugs interact with the liver in different ways. So we have some drugs that have a very high intrinsic clearance, like etomidate and propofol. Their hepatic clearance is basically their blood flow. As fast as you can send them to the liver, that's how fast they'll be metabolized. And so we call this flow-limited metabolism. And if you drop their cardiac output really low, let's say you make them hypotensive or injure their heart, well then they're going to take longer to eliminate these drugs with the liver. We also have some drugs that have a relatively low intrinsic clearance, like thiopental and diazepam. These drugs, no matter how much flow you send to the liver is not going to do a very efficient job of metabolizing them. These drugs have a low extraction ratio, and really their hepatic clearance is limited by their intrinsic clearance. Again, we'll talk about this idea a little bit more in class, but it's something you should think about for a little bit. We have lists of where drugs fall in the low, intermediate, or high hepatic extraction ratios. If we're talking about midazolam, it tends to be sort of intermediate. And you don't need to memorize this list, but just be aware that not every drug is eaten up by the liver in the same way. And it's interesting to contrast this with the kidney, where you have something called autoregulation. Autoregulation means it doesn't matter whether you send a little bit of blood flow or a lot of blood flow to the kidney. The kidney does a pretty good job of maintaining renal blood flow regardless of what the cardiac output is. And on that note, we're actually going to speak about the kidney for a minute. The kidney is usually the way most of our drugs leave the body. Renal drug clearance, again, clearance is this question of what volume of blood could I totally clear out of drug in a certain period of time. So we have something called the glomerular filtration rate, which is the amount of blood that's filtered into the kidneys. It's about 20% of your renal blood flow, actually. And if that's all we relied on, just passive filtration, that's not really enough. It would take forever to get enough drug into the kidneys. This 20% of renal blood flow isn't enough. So actually, we have transporters that will not only just filter the blood, but actually transport drugs from the blood into the kidney as well. Now, patients who have low renal function may need you to change your drug dosing, because otherwise the kidneys won't be able to clear the drug fast enough, and you'll start to build up levels of drug in the body. And you don't want to accumulate drugs, not the parent drugs, and sometimes we have active metabolites which can accumulate and be just as dangerous, sometimes even more dangerous. So here's a non-exhaustive list of drugs that have significant renal excretion. Certainly we know that drugs like pancuronium, rocuronium are drugs that are excreted by the kidney, and we don't want to overdose patients with these. But there are many others besides just these neuromuscular blocking drugs, some antibiotics, and a variety of other drugs. We'll stop this part here for you to make note of any questions that you have or concerns, and you can contact me or we can discuss them in class.